Yeah, for me it certainly has. And especially with respect to respiratory cases, in trying to discern whether or not I'm dealing with an inflammatory condition in the lower respiratory tract as opposed to an infectious condition. A lot of our inflammatory airway disease cases, they require corticosteroids. So it's pretty imperative that we eliminate the possibility of a bacterial component before we address those cases therapeutically, whether it's systemic steroids, parenteral steroids, or inhaled corticosteroids. So it's been very useful in helping me distinguish between an infectious versus inflammatory respiratory condition. It's much more accurate. And the kinetics of serum amyloid A are just so different. It's almost more real time. And as opposed to fibrinogen, where the kinetics are somewhat delayed, and you're going to get an increase in your fibrinogen in maybe 7 to 10 to 14 days, your SAA is more real time. You get a very quick rise in your SAA as a result of mostly bacterial infections. And so it's just so much more reliable. And again, there's so many other factors that can affect the white blood cell count. And historically, everyone's, we used to look at the white blood cell count, we used to look at the fibrinogen and base our treatments or course of treatment on those values. And it's interesting to look at how we manage these cases now with the advent of Stabilab and the SAA, because we manage them very differently. It's definitely revolutionized or changed the way that we look at some of these cases. I think it makes us a better clinician, and our ability to not only detect illnesses, but to monitor them and monitor them accurately through the course of treatment, certainly improved the way that we practice.